Welcome to the audio digest of the American Journal of Psychiatry. This is Dr. Susan Schultz with highlights for the month of May 2007. Please note that the full text of all articles may be viewed online at hap.psychiatryonline.org, including all author affiliations and disclosures. This month, we are featuring a series of articles on psychotherapy. 2 of them involve treatment with interpersonal therapy. 2 others describe treatment with cognitive therapy in the STAR-D study. Myrna Weissman provides a context for these articles in her editorial. In an additional study by Sidney Kennedy and colleagues, cognitive behavior therapy was compared with drug treatment using brain imaging as an outcome measure. The results are presented in the article, Differences in Brain Glucose Metabolism between Responders to CBT and Venlafaxine in a 16-week randomized controlled trial. We'll also present highlights of this month's clinical case conference entitled Psychiatric Sequela of Traumatic Brain Injury, a Case Report by Vani Rao and colleagues. Next, we'll present an article on treatment for heroin dependence by Johan Kako and colleagues. The title is A Stepped Care Strategy Using Buprenorphine and Methadone versus Conventional Methadone Maintenance in Heroin Dependence, a randomized controlled trial. We'll conclude with 2 articles on endophenotypes for schizophrenia. The first is entitled Substantial Shared Genetic Influences on Schizophrenia and Event-Related Potentials by Mehua Hall and colleagues. The second article is Neurocognitive Endophenotypes in a Multiplex Multigenerational Family Study of Schizophrenia by Raquel Gurr and colleagues. The articles are discussed in an editorial by David Braff. Now we'll turn to our series on psychotherapy. Myrna Weissman ties 4 of these articles together in her editorial, Cognitive Therapy and Interpersonal Psychotherapy, 30 Years Later. 2 articles derive from STAR-D, which is the Sequenced Treatment Alternatives to Relieve Depression trial. STAR-D was designed to determine what options should be considered in successive treatment alternatives for depressed outpatients who do not benefit adequately from an initial course of an antidepressant. The report by Michael Thays and colleagues is titled Cognitive Therapy versus Medication in Augmentation and Switch Strategies as Second-Step Treatments, a STAR-D report. The STAR-D design allowed patients who did not remit while taking citalopram to choose their next treatment within a randomized design. This design permitted the assignment of participants to either augmentation of their citalopram with cognitive therapy or augmentation with medication. Alternatively, they could switch to cognitive therapy or switch to an alternative antidepressant. Patients could elect not to be assigned to certain treatment strategies and were eligible to remain in the study as long as random assignment was possible for at least one strategy. Among the strategies that involved augmentation with another treatment, cognitive therapy was found to be as effective as medication, but medication augmentation produced more rapid remission. Among the strategies consisting of a switch to a different treatment, cognitive therapy and medication were equally effective, but a medication switch was associated with more side effects. The surprising point in this article is not the outcome, but the fact that only a quarter of the patients chose cognitive therapy, either as an augmentation or a switch strategy. This low level of patient preference for cognitive therapy is at variance with earlier research by the same investigators. However, the authors discussed design issues that may have biased the choice, so we cannot conclude that depressed patients do not want cognitive therapy. For example, patients who entered the study had to be willing to take medication as the only initial treatment option. Furthermore, patients who were already participating in psychotherapy could be enrolled in STAR-D, but when the time came for augmentation or switching, those who wish to continue their current psychotherapy may have declined random assignment to cognitive therapy because that would have meant giving up their relationship with an outside psychotherapist. There were also convenience issues. Patients receiving cognitive therapy had to go to an off-site office. The study did not reimburse for copayment charges for psychotherapy covered by insurance, whereas all medication charges were covered. These findings are followed up in the article by Stephen Wisniewski and colleagues, Acceptability of Second-Step Treatments to Depressed Outpatients, a STAR-D report. These authors sought to understand patients' willingness to accept the various switching or augmenting second-step strategies. The factors related to the choice of cognitive therapy as a second-step treatment were better education and a family history of depression. Since education is associated with income, it is possible that this finding is a reflection of the need to pay the costs of cognitive therapy not covered by insurance. Higher income patients may have had better insurance coverage and might not have incurred much or any out-of-pocket expense. Patients' choices regarding a switch from the initial medication treatment were clinically intuitive. For example, patients who had more side effects with the first medication or obtained inadequate benefit from it wanted to switch to something different, usually a different medication. But patients did make individual choices. Few patients accepted all 4 strategies offered. As we look at our other articles in the psychotherapy series, the issue of psychotherapy dose was studied by Ellen Frank and colleagues. Their article is titled Randomized Trial of Weekly, Twice Monthly, and Monthly Interpersonal Psychotherapy as Maintenance Treatment for Women with Recurrent Depression. The women in this study received weekly interpersonal psychotherapy during acute treatment. If they required medication for acute symptoms, they were given a selective serotonin reuptake inhibitor in addition to psychotherapy. After remission, the women were randomly assigned to psychotherapy weekly, twice monthly, or monthly. This was their sole therapy for 2 years or until a recurrence. Overall, 26% of the women who received interpersonal psychotherapy only during the acute phase experienced a recurrence during maintenance treatment. For women who required the addition of an SSRI during acute treatment, the recurrence rate was 50%. However, in neither group did the frequency of psychotherapy make a difference. About 2/3 of the women achieved remission with interpersonal psychotherapy alone in acute treatment, and for them, monthly psychotherapy is a good maintenance treatment. But for women who need the addition of medication during acute treatment, interpersonal psychotherapy alone as maintenance treatment, regardless of the frequency, is not a good choice. The article by Elizabeth Schramm and colleagues is titled An Intensive Treatment Program of Interpersonal Psychotherapy plus Pharmacotherapy for Depressed Inpatients, Acute and Long-Term Results. The authors tested a new indication and dose for interpersonal psychotherapy, that is, treatment of depressed patients with a high dose of psychotherapy. Hospitalized patients in Germany received pharmacotherapy plus either intensive psychotherapy or standard clinical management. Interpersonal psychotherapy was delivered individually 3 times a week for 5 weeks, and 8 group sessions were conducted during that period. Significant others were also educated about the illness. This program was superior to standard treatment, and the differential effects lasted for 3 months. The authors conclude that it is best to begin intensive treatment early and not wait for a period of stabilization to add psychotherapy. This approach is quite feasible within the health insurance systems of Germany and some other countries, but less so in the United States, where few insurance plans will pay for this amount of hospitalization or even for this amount of psychotherapy for outpatients. Dr. Weissman notes that there are clear differences between the 2 psychotherapies used in these studies. Cognitive therapy addresses distorted, negative thinking associated with depression, whereas interpersonal therapy addresses stressful social and interpersonal relationships associated with the onset of depressive symptoms. Unlike medication, few psychotherapies for depression have undergone extensive testing in clinical trials. Psychotherapy has been a cottage industry without support from commercial companies for developing and testing new psychotherapies or new indications for old ones. Many widely used psychotherapies remain untested, and studies directly comparing psychotherapies are rare. 30 years after cognitive therapy and interpersonal therapy were conceived, we are still looking at dose, effectiveness, and new indications. If these two psychotherapies were medications, by now there would be off-label uses, generic versions, and numerous other second and third generation psychotherapies in clinical trials. As the study by Frank and colleagues shows, psychotherapy could have been offered as the first option in STAR-D. The argument that psychotherapy is not common in community practice really depends on what community one looks at. If all the health professionals treating depression are included, a different conclusion may be drawn. A representative survey conducted in the United States in 1997 found that 74% of adults presenting for outpatient treatment of depression received an antidepressant, and 60% received psychotherapy. Future large-scale clinical trials for depression might have the option of beginning with psychotherapy alone or in combination with medication. However, this approach might face practical problems in clinical implementation. While psychiatry has taken a step forward with its new resident training requirements for teaching cognitive therapy and for its required supervision in other evidence-based psychotherapies, many in the psychotherapy workforce are not psychiatrists and do not receive information on medication options or training in evidence-based psychotherapies. The 4 articles in this issue support the value of new training efforts in multiple evidence-based psychotherapies. This concludes the editorial by Myrna Weissman. Please refer to the May issue for the full editorial and the articles it covers. Next, we'll turn to the article by Sidney Kennedy and colleagues, Differences in Brain Glucose Metabolism Between Responders to CBT and Venlafaxine in a 16-week randomized controlled trial. The author's aim was to identify regional changes in brain metabolism that are common to both psychotherapy and pharmacotherapy, as well as changes that differ between patients who respond to cognitive behavior therapy and those who respond to venlafaxine. Patients experiencing a major depressive episode were randomly assigned to CBT or to venlafaxine for 16 weeks. Response was defined as a reduction of at least 50% in the score on the Hamilton Depression Scale. This criterion was met by similar proportions of patients in the 2 groups. These 2 groups of responders showed both similarities and differences in their changes in brain metabolism. Both had decreased metabolism in the left and right lateral orbital frontal cortex, the left dorsomedial prefrontal cortex, and the cerebellar vermis, along with increased metabolism in the right inferior occipital cortex. In some brain areas, the direction of change differed between the 2 groups. Response to venlafaxine was associated with increases in the head of the caudate, the putamen, and the posterior cingulate, but CBT responders displayed decreased metabolism in these same brain regions. Conversely, metabolism in the left inferior temporal cortex increased with CBT and decreased with venlafaxine. Metabolic changes unique to each treatment modality were also observed. Response to CBT was associated with modulation of cortical limbic connectivity, while venlafaxine engaged additional cortical and striatal regions previously unreported in neuroimaging investigations. The decreases in metabolism in the ventrolateral and dorsomedial prefrontal cortices of both responder groups have previously differentiated depressed and euthymic states in patients with major depressive disorder. Preclinical data implicate the ventrolateral and orbital frontal cortices in the behavioral and visceral responses to defensive, fearful, and reward-directed behaviors. Moreover, depressed patients' biases in emotional processing have also been shown to map onto the orbitofrontal cortex. In this analysis, response to either treatment was associated with a reduction in metabolic activity bilaterally in the orbitofrontal cortex. Decreases in activity in the dorsomedial prefrontal cortex were also observed in both treatment groups. This region has been implicated in the self-referential processing of emotional stimuli. Clinical experience suggests that some patients respond better to psychotherapy and others respond better to pharmacotherapy. This study helps to build an evidence base for differential changes in regional brain activity following response to pharmacotherapy compared with psychotherapy. Exploration of baseline differences between venlafaxine and CBT responders may also be helpful in understanding which patients are best served by each of these interventions. Now we'll turn to this month's clinical case conference, Psychiatric Sequelae of Traumatic Brain Injury, a case report by Vani Rao and colleagues. Designing a comprehensive treatment plan for this patient was challenging, but a framework for organizing the patient's history and clinical management was provided by viewing this case from multiple perspectives. Mr. C was a 42-year-old man who was referred to an inpatient neuropsychiatry unit for evaluation and management of behavior problems associated with traumatic brain injury. After both inpatient and outpatient rehabilitation, he was still unable to hold a job because of socially inappropriate behavior, such as arguing with male coworkers and inappropriately touching female coworkers. He was arrested twice and incarcerated once because of these acts. Other behavior problems included frequent outbursts of anger and physically aggressive behavior, leading to separation from his wife and alienation from several family members. At the time of his admission, Mr. C was most concerned about intermittent episodes of depression. Before the brain injury, Mr. C had no history of psychiatric symptoms or treatment. His father described his personality before the injury as happy-go-lucky but conscientious. A neuropsychological assessment revealed dysfunction of the frontal subcortical system, with impairments in processing speed and visual sequencing, as well as impairments in set shifting. Relative weaknesses were found in divided auditory attention, sustained visual attention, social judgment, verbal and visual learning and memory, and fine motor coordination. Baseline verbal intellect was estimated to be average. Assessment of psychiatric symptoms revealed mild to moderate symptoms of depression. On the inpatient unit, Mr. C remained compliant and had no behavior problems. Sertraline was titrated to 150 milligrams per day for his depressive symptoms. Amantadine was started to address his frontal lobe symptoms, such as impulsivity, poor social judgment, low frustration tolerance, and behavioral disinhibition. The dose was gradually increased to 100 milligrams per day. Mr. C was discharged and referred to a brain injury clinic, a sexual disorders clinic, and a psychosocial rehabilitation program. Mr. C found it difficult to return to community living. Establishing realistic expectations was critical to his care, and the primary goals of therapy were to minimize existing disability and maximize productivity. Successful treatment emerged from disentangling his symptoms and their respective causes by viewing them from 4 perspectives. The disease perspective focused on his brain damage. This could not be cured, but the disinhibition and depression associated with damage to the prefrontal cortex and limbic structures could be minimized by the sertraline and amantadine that Mr. C was already receiving. The central theme of the dimensional perspective is that emotional distress can be secondary to an individual's cognitive or affective traits. Treatment for the dimensional problem focused on factors precipitating Mr. C's emotional distress and on strategies to reduce his emotional response. During individual therapy, Mr. C was educated about brain injury. His strengths and weaknesses were also discussed. His strengths included his motivation to get better, his desire to be self-sufficient, and an absence of substance abuse. Discussing his strengths improved his self-esteem and helped him to stay motivated. His weaknesses included his cognitive deficits and specific personality traits. Modeling and role-playing were used to demonstrate how these could lead to trouble. Guidance also included training to improve his interpersonal relationships, with an emphasis on learning to listen, exercising self-control, and making polite conversation. Group counseling was useful in providing actual interactions with peers and opportunities for socialization. This supportive and structured setting gave Mr. C an opportunity to obtain safe feedback from peers. In addition, regular family meetings were held. Mr. C's sexually inappropriate behavior was addressed by using the behavior perspective. Even though injury to the frontal lobes may have resulted in Mr. C's vulnerability to hypersexual acts, this behavior was probably shaped and maintained by positive reinforcements such as attention. Management of these behaviors included a combination of pharmacotherapy and psychotherapy. The increased sexual drive was reduced pharmacologically with leuprolide. Psychotherapy included group and individual therapy that included recommendations for maintaining acceptable behavior. Examples include avoiding places where he was likely to be vulnerable to hypersexuality, having a responsible person supervise him when he was meeting with friends, and role-playing his actions before his dates. The transient episodes of sadness and hopelessness that Mr. C experienced are best explained by the life story perspective. This perspective tries to explain distress as an outcome of events that have taken place in a person's life. The goal of therapy from this perspective is to re-script events and the negative meanings adopted by the patient. Individual and group therapy often help the person to reinterpret his or her life by providing an understanding of the setting and sequence, and by developing coping skills and compensatory strategies to modify the outcome. Ultimately, the patient is encouraged to continue his or her life with an acceptance of past events and renewed optimism. Mr. C had limited self-awareness, perhaps because of the right frontal injury. Regular education, individual and group therapy, and gentle confrontation of inappropriate behavior all played a role in increasing Mr. C's awareness of his deficits and improving his behavior. Although he is by no means cured, the individually designed treatment helped him make significant improvements and increased his overall quality of life. This concludes the clinical case conference. Now we'll turn to an article on treatment of substance dependence by Johan Kako and colleagues. The title is A Stepped Care Strategy Using Buprenorphine and Methadone versus Conventional Methadone Maintenance in Heroin Dependence, a randomized controlled trial. The utility of methadone maintenance therapy is partially limited by its potential for death by overdose. Buprenorphine offers a decreased overdose risk. Accordingly, buprenorphine but not methadone is approved for office-based use in the United States. A shift to approaches based on buprenorphine therefore has the potential to reduce deaths from methadone overdose and to improve access to treatment. Some studies indicate that methadone is more efficacious than buprenorphine. Therefore, a flexible stepped strategy using both compounds might achieve an optimal balance of safety, accessibility, and efficacy. To test this hypothesis, the authors evaluated a stepped strategy using a combination preparation of buprenorphine and naloxone that is approved for office-based treatment in the United States. Patients with heroin dependence were randomly assigned either to the stepped treatment or to standard methadone maintenance. Patients in the stepped program started with a standard dose of the buprenorphine-naloxone combination. The dose could be escalated to the maximum approved dose of 32 milligrams per day. If the clinical effect remained insufficient at this dose, the patient was transferred to methadone, which could be further escalated. With this method, all patients who needed methadone ultimately received it, but those who did not could be successfully treated without it. Treatment lasted for 6 months. Transitions were possible at intervals of 2 weeks. A transition involved a dose increase, or for the patients receiving the maximum buprenorphine dose, a switch to methadone. The criteria for transitions were 2 or more missed visits within the preceding 2 weeks, insufficient blockade of craving, withdrawal symptoms, or any urine sample positive for illicit opiates with no signs of overdosing. The standard methadone maintenance allowed transitions in 10 milligram increments up to 120 milligrams per day. Stepped therapy allowed transitions in 8 milligram increments to 32 milligrams per day of buprenorphine. If this dose was insufficient, a rapid switch followed. Patients received 50 milligrams of methadone the day after the last buprenorphine dose, followed by 10 milligram increases every second day, up to 90 milligrams per day. After this, the protocol for standard methadone maintenance was followed. Patients met with case managers at least weekly for counseling and to provide information for dose adjustments. Patients also participated in group relapse prevention therapy for 12 weeks. 96 patients were randomly assigned to treatment. Overall retention was 78%, and the rates were virtually identical in the two treatment arms. Of the 37 patients receiving buprenorphine, 17 remained on the medication throughout, and 20 required a switch to methadone. Age, gender, duration of heroin use, and baseline severity did not predict which patients in stepped therapy would require a switch to methadone. The proportion of urine samples that were free of drugs increased over time, and no difference between the two treatment groups was found. There was also no difference in the decrease in severity of symptoms as measured with the Addiction Severity Index. No serious adverse events were reported that were assessed as attributable to study medication. Next, we'll turn to two studies that examine the genetic basis of neurophysiological and cognitive measures with the potential to be used as endophenotypes of schizophrenia in genetic studies. One of these studies is by Mei-Hua Hall and colleagues. It is reported in the article, Substantial Shared Genetic Influences on Schizophrenia and Event-Related Potentials. This study measured three components of event-related potentials: mismatch negativity, P300, and P50 suppression. The measurements were compared in monozygotic twin pairs concordant for schizophrenia, monozygotic pairs discordant for schizophrenia, and healthy comparison twin pairs. Each of the physiological measures showed substantial genetic overlap with schizophrenia, but P50 suppression and P300 amplitude had the closest genetic relationship to schizophrenia. The related article is by Raquel Gur and colleagues. It is entitled Neurocognitive Endophenotypes in a Multiplex Multigenerational Family Study of Schizophrenia. Several measures of memory, mental processing, and attention were found to be genetically linked to schizophrenia. The findings from these articles are discussed in an editorial by David Braff and colleagues titled Endophenotyping Schizophrenia. The following include highlights from the editorial. Multiple genes appear to be involved in schizophrenia. Because most analyses of genetic effects can be performed only on one gene at a time, gene hunting in schizophrenia becomes a risky business, fraught with uncertainties in research design and analytical conundrums. One way to determine the genetic architecture of schizophrenia is the endophenotype strategy illustrated by the Hall and Gur articles. This strategy investigates the genetic basis of subclinical endophenotypes, each of which is hypothesized to reflect more directly the effect of a single gene than the overall illness itself. The illness is then conceptualized as the product of the interaction of multiple genetically influenced endophenotypes along with environmental factors. Of course, the ultimate endophenotypes are perturbed levels of specific proteins or gene expression induced by inherited DNA sequence variations. This level of analysis is not yet possible in schizophrenia. Therefore, investigators turn to neurophysiological and neurocognitive measures that seem to reflect more elementary aspects of the biology of the illness rather than the clinical features themselves. For example, poor processing of simple sensory information might be a more discrete reflection of a genetically determined brain dysfunction than a complex symptom such as persecutory delusions. Thus, Hall and colleagues examined a set of well-known electrophysiological abnormalities that have been associated with schizophrenia. Gur and Associates chose a neurocognitive battery that has previously shown deficits in neurocognition in schizophrenia. Because there is no proven strategy to select brain dysfunctions that are linked to genes, investigators performed several tests to determine their relationship to the genetic transmission of schizophrenia. Here, 2 different methods were chosen. The Hall study examined heritability in monozygotic and dizygotic twins, including twins concordant and discordant for the illness itself. This analysis of heritability is based on the model that monozygotic twins share all genes and dizygotic twins share half their genes, as do all siblings. To the extent that a deficit in an endophenotype is genetically determined, it should be, on average, only 50% similar in the dizygotic twins and 100% similar in monozygotic twins. Hall and colleagues used a sophisticated analysis to determine the actual fit of the data with this model. They also determined to what extent the similarity in endophenotypes resembled the sharing of risk for schizophrenia. They found that deficits in these electrophysiological measures of sensory processing were transmitted genetically, and that the genetic transmission of these deficits was correlated with the genetic risk for schizophrenia. The discordant monozygotic twins, one with schizophrenia and one without, are especially informative because the failure of one twin to develop the illness suggests that the same environmental factor present in the ill twin has combined with the genetic factors present in both twins to produce the illness. Any abnormality measured as an endophenotype in the clinically well twin would then be presumed to reflect the genetic aspects of the illness. The electrophysiological measures used by Hall and colleagues have the advantage that they represent simple neurobiological functions, but deficits in responses to a series of clicks and tones are not immediately applicable to patients' problems in functioning in the real world. Gur and her colleagues used a set of cognitive tests that are felt to be more closely related to real-life functioning. Performance on these tests of perception, attention, social cognition, and memory has been linked to psychosocial dysfunction in schizophrenia, such as employability and sustainability of interpersonal relationships. Instead of twins, this analysis relied on multi-generational sibships, in which schizophrenia is present in multiple siblings in one generation, as well as members of another generation, such as parents and uncles and aunts. The genetic analysis is similar in principle to the analysis performed in the Hall study of the twins. Siblings are expected to share 1/2 of their genes with the other sibling, as well as half their genes with their parents. Uncles and aunts would be expected to share 1/4 of their genes. The extent to which performance on the neurocognitive test follows this pattern determines heritability. The exception is those members of the family who have schizophrenia. If their illness is caused by the same genetic variants, then all of the affected members of the family should have these variants. Gur and colleagues found heritable deficits across a number of domains, including memory and spatial and emotional processes. They took into account not only accuracy on these tests, but also speed, because many persons with schizophrenia can manage to perform a task accurately, presumably by using more effort than other persons, but then it takes them longer to perform the task. Looking at speed as a criterion, the investigators found additional deficits in abstraction, face memory, and attention. Establishing the heritability of endophenotypes and schizophrenia is crucial, but still only a first step in dissecting the genetic basis of the disorder. The next step is to identify actual genes and genetic variations that contribute to the heritable fraction of the endophenotypes and to the genetic transmission of schizophrenia itself. This concludes the audio highlights of the May issue of the American Journal of Psychiatry. We invite you to refer to the online issue at ajp.psychiatryonline.org for the full text of these and other articles. Thank you.